I think we can get started now. So just like to welcome all of the listeners to our webinar series on COVID-19 and global health. I am Sheila Maru. I'm a faculty member at the Arnhold Institute of Global Health, and I'm an obstetrician gynecologist at Elmhurst Hospital in Queens. I have worked in communities in rural Nepal for the past 10 years, as well as urban hospitals in the US serving marginalized populations. And I've seen at baseline, before COVID, how reproductive rights have often been under threat due to policies and issues of access. During this unprecedented time of national and global public health emergency, we've seen that these rights have even been further jeopardized. And I'm honored to have Dr. Kristen Brandy and Catherine Bodie here to discuss their critical work in protecting reproductive rights. For the listeners, I do want to let you know that as questions come up during the webinar, you can place them in the Q&A box, which is at the bottom of your screen, and we'll be able to see them, and we'll take questions during the last 15 minutes from that box. So before we start, I'd like to briefly introduce our speakers. Catherine Bodie is a lawyer who specializes in gender equality and reproductive rights. And prior to joining the New York Civil Liberties Union in 2009, Catherine worked as a legal educator in Cambodia, focusing on violations of women's rights and citizens' land rights. The work combined her background as a New York City teacher and her commitment to fighting violence and poverty by empowering women. Catherine has also worked at the Office of the United Nations High Commissioner of Refugees and as a volunteer immigration attorney, worked with asylum seekers. She currently teaches a course at Cardozo Law School on reproductive rights law and justice, and is the chair of the Sex and Law Committee at the New York City Bar Association. Catherine graduated from Brooklyn Law School with special recognition for her work in international law and women's rights and her strong commitment to public service. So welcome to Catherine. And Dr. Kristen Brandy is an assistant professor at Rutgers, New Jersey Medical School, where she completed her medical school and residency. She completed a family planning fellowship at Boston University, where she also earned a master's in public health with a concentration in health law, bioethics, and human rights. And I was fortunate to have worked with Dr. Brandy during her time in Boston. Her research is on reproductive decision-making, contraceptive coercion, and racism in reproductive health care. She serves as the board chair of Physicians for Reproductive Health and sits on several subcommittees for the Society of Family Planning, and is also the founding member of Centering Equity, Racial, and Cultural Literacy in Family Planning. She proudly identifies as a Latina bisexual abortion provider, and her pronouns are she, her, and hers. So welcome to Chris and Catherine. So to start, I would like to ask you both to explain to our listeners today how reproductive rights and healthcare have both been impacted in the communities that you serve and more broadly since the outbreak of COVID-19. Catherine, would you like to start?
Absolutely. So first, thank you so much for having me and creating space for this conversation. I think that these types of conversations are so important right now, and I think that we're all so inundated with information that it can be difficult to concentrate, to say the least. So I hope that everyone who is on and listening is doing okay. Chris is certainly well situated to talk about the more specific challenges in delivering care that providers are encountering during this time. I think from my perspective, broadly speaking, I just want to note that this has been such an extraordinary time of insecurity and fear across the board for so many people. And people are at home in difficult situations. People are going to work and exposing themselves and their families to the virus. And being pregnant at this moment in history adds a layer of complexity that's hard to imagine. And that's regardless of whether you're trying to have a child or whether you're trying to end a pregnancy. And you know, as we all know, abortion access already feels so precarious for people in this country. And if you're isolated with people you can't involve in that decision or need to travel to get care and are facing restrictions or are in a state where the state's policy has deemed abortion as non-essential and are shuttering clinics, or if you've lost your job and just cannot afford to pay for care. All of this exacerbates the tenuous nature of navigating an already unsustainable and politicized web that is accessing abortion in this country, in this healthcare system. And it's important to also mention that if you're pregnant and considering your birthing options, it is certainly a frightening prospect to go to the hospital right now, especially in areas that are really hard hit, like New York City. So I just want to say before passing it off to Chris, that I always think that women's healthcare providers and abortion providers are heroes, and they, like so many of their healthcare colleagues right now, have stepped up in this crisis to make sure that people can get the care they need. So thank you for that.
Thank you. Yeah, Chris, go ahead.
Sure. Thank you so much for that, Catherine, as well. And thank you for having me. And also echo one of the sentiments that I hope everyone that's listening is safe, either sheltered or doing what they can to stay safe and protect themselves and their families. It's definitely been a rough couple of weeks. As Sheila mentioned, I'm in New Jersey, and we have the second highest number of cases, including deaths in the US, secondary to New York and New York City. There's been so many changes in the past couple of weeks in order to accommodate the COVID pandemic. I know patients are scared, that they're worried about seeking care, and healthcare providers are struggling to figure things out on the fly. Recommendations are changing every single day, and we're trying to do our best to accommodate the burden of additional patients in our hospitals, in addition with the trauma in itself of providing care at this point, given that we're all worried about bringing the virus home with us. I've shared elsewhere that I recently came down with COVID. I was positive a couple of weeks ago and was facing quarantine. I was very fortunate that I had minimal symptoms, that my partner and I were sheltered for a week and then were able to go back to work. So I'm very lucky in that regard, but the reality is very real of us going to work every day with the concerns of us going home with COVID, and bringing it to ourselves or our family members. I think thinking about reproductive health care at this point, a lot of the fear and anxiety that people are having already around COVID is exacerbated when you're thinking about reproductive health care. I'm really lucky that I work in a state where our governor has deemed abortion to be an essential healthcare service, and that I'm still able to provide that care. But I know that my colleagues elsewhere in other states are struggling to figure out how to take care of their patients when there's not that protection there, or when clinics are being shuttered because of these stay-at-home orders or non-essential healthcare orders. I think it's a challenge not only for abortion care, but also, like was mentioned, for birth care and for infertility care, for all the care around reproductive health and reproductive justice. To be able to provide that for patients has been really challenging. And there's a lot of logistics that we have to work through to make it work. I'm reminded that in the past week or so, our hospital has implemented that we have to do mandatory COVID testing 48 hours before all procedures, including abortion services, which in general, trying to navigate all the logistics around providing abortion care is enough work. But making sure our patients are safe at this time to get their abortion services without having to worry about COVID is an additional challenge. And for some places, it's a big barrier for people being able to access care. But I'm really glad that many of us in reproductive health rights and justice movement are echoing the fact that abortion care and all reproductive health care is time-sensitive and essential care that shouldn't be delayed in general, but particularly during this public health crisis.
Yeah, definitely. Thanks for that. And also for sharing your personal story, Chris. You both kind of mentioned how there are challenges and struggles, even before COVID. But I was wondering if you could describe some of what you've witnessed and learned about how COVID-19 is exacerbating those underlying systemic injustices with regards to reproductive rights, specifically, in New York City or New Jersey, or also across the country, as I know you're both involved nationally as well.
So I can, Kristen touched on this, and I certainly want to lift up how government policies during this public health crisis can really prevent access to reproductive health care and exacerbate the disparities within our system. Over the past month plus, we have seen states across the country restricting non-essential medical procedures, and under this guise, some states are using these emergency orders to delay and in some cases deny access to abortion by classifying abortion as non-essential, as Kristen was referencing. And it's important to say abortion is healthcare, and healthcare is essential. But despite the fact that this is widely recognized by many in our medical community, including the AMA, including ACOG and others, what we're seeing is lawmakers continuing to play politics with people's lives, with women's lives when it comes to access to abortion. And I'm specifically talking about Texas, Oklahoma, Ohio, Iowa, and Alabama. These states have a real history of trying to ban abortion. I mean, just last year, we saw Alabama passed a law banning nearly all abortions and threatening to put abortion providers in jail for up to 99 years for providing abortion. Last year, we also saw Ohio and Iowa banning abortion at 6 weeks. And all of these laws have been blocked by courts because they are, of course, unconstitutional. And so are these latest state actions. So we need to keep that in mind. And, I think what is particularly stomach turning about all of this is how these states are really exploiting a global health crisis to deny people access to time-sensitive and medically necessary care. Fortunately, organizations, our partner organizations and the ACLU are going to court to file for emergency orders to stop them from going forward. But clinics have already had to cancel hundreds of procedures, and some of the harrowing stories that I have heard about patients traveling across the country to get the care they need or just being denied care, period, is just awful. In most states, abortion is being treated like healthcare, and providers are able to determine what is essential and how to keep patients safe, as Kristen was talking about. And it needs to be the same across the board.
Yeah, thank you, Catherine, and also for highlighting, the real intense effort for more court cases to kind of put a halt on some of these unconstitutional policies that are coming out. I don't know if you have some specific examples of how that is playing out, recently in terms of these court cases.
Well, I'll tell you, I mean, the situation is very fluid, and certainly it was changing by the day this month. Fortunately, some of the orders, the executive orders, were struck down by courts. There was some back and forth, for instance, with the Texas executive order. And some of them have also been resolved because restrictions are expiring or being lifted. I mean, it's interesting how these are also happening in states that are now wanting to open the barbershops and the nail salons. So, it's hard to open the barbershops and the nail salons and still continue to shut down abortion providers. So I think that is going to be something that also plays into the resolution of this.
Yeah, that is interesting. So thank you. Chris, I'll turn it to you.
Sure. Well, I want to thank Catherine for highlighting all the restrictions around abortion and how I agree that many politicians are using this as an opportunity to restrict care. when there's no medical reason to do so. And in fact, we know that abortion is essential healthcare. And so preventing access is just perpetuating a lot of the injustices that happen in healthcare that politics interferes with. I particularly wanted to highlight some of the injustices around vulnerable populations that's being exacerbated at this point. We know that there are historic inequities within healthcare that disproportionately affect communities of color and other vulnerable people. And COVID-19 is just highlighting a lot of those inequities. So for example, we know within this COVID pandemic that it's disproportionately affecting communities of color, particularly Black communities, and that they have higher rates of morbidity and mortality compared to white patients. And while some people are shrugging this off as, well, those patients may be at high risk because they have these factors in their health that make them high risk. When in actuality, a lot of these so-called risk factors or social determinants of health are related to inequities that exist within the healthcare institution. So things like income inequality, environmental justice, a lot of these things that we already knew about that impact healthcare outcomes, reproductive healthcare outcomes poorly, are being perpetuated and exacerbated right now. Also, to give a shout out to the healthcare workers and other essential workers, they also have to be disproportionately people of color. And so that also creates exacerbating issue around people being exposed and who is actually at risk of getting exposed. To circle that back to reproductive healthcare, reproductive healthcare like abortion also has a lot of issues with vulnerable populations having access. And so people that have issues around transportation, there's even less opportunities right now for transportation, particularly if you need care across state lines. So I think I'm hopeful that COVID is creating this spotlight on a lot of these inequities that we have in healthcare, but I'm hopeful that it's not going to go away once COVID goes away, that we hold on to that spotlight and keep that light shining on all of these inequities and work to really examine them and dismantle them as we move forward.
Thank you. Thanks, Chris. Yeah, I think that is really very important to keep in mind. And you mentioned the specific example of transportation crossing state lines, which is something that a lot of vulnerable communities had to face before COVID. And I was wondering if you had other examples of how particularly, certain communities are being more affected by the reproductive rights restrictions that are occurring right now, perhaps in your own hospital or other communities that you've been following or supporting.
Well, like you said, a lot of the issues around logistics are highlighted now. So issues around transportation, issues around cost. Some places you have to pay out of pocket in order to obtain any type of healthcare services. And abortion particularly has limited insurance coverage. And so many people end up paying out of pocket to get their care, which is hard on a regular day. But for people that are more and more coming out of work and losing their jobs, I worry about my patients being able to access care if they're having to pay out of pocket and just lost their job and having to figure out whether or not they want to access healthcare or if they need to put food on the table. So transportation. I also think about patients that are getting care from a detention center, if they're detained due to immigration status, or people that are incarcerated and how they're at risk given this the situation of their living situation right now, and how that is already a problem and access to care is already difficult, but their risk to getting infected in addition to limited access to care is really problematic.
Thank you. Okay. So, and I know, Catherine, you alluded to this a little bit more earlier, but in your perspective, what policies and specific laws most urgently need to change at this time? And you can kind of also speak specifically to the work of your specific organizations on this advocacy effort.
Sure. I mean, I also want to lift up, I think a lot of the work when it comes to accessing reproductive health care services, I think has shifted during this time in thinking about how to improve access to care, but improve access to care without putting people at risk. And that means greater access to telemedicine. It means reducing trips to clinics. So certainly I think, as I mentioned, states need to stop politicizing access to reproductive health care and drop attempts to categorize abortion as elective or non-essential. But there are state laws across the country that I think Kristen referenced that, for instance, require 2 trips to the clinic before getting an abortion. Other kinds of, people are familiar with calling them trap laws. And these kinds of laws are now not only clearly medically unnecessary, but are also putting people in danger. And there's 2 more that I want to lift up that the folks who are in attendance today may be familiar with. I think a policy that I want to underscore here is the medically unnecessary FDA requirement that medication abortion be dispensed physically in the healthcare facility. The ACLU has challenged that before this pandemic broke out, but it is certainly the pandemic that lifted up the real need to change that requirement and how that requirement is putting people at risk and exacerbating the spread of the virus. So I would certainly lift that up as something that that needs to shift on the federal level. And a second thing to lift up on the federal level is also the Hyde Amendment. This is, of course, an annual rider that is attached to the federal budget that prohibits Medicaid funding for abortion. It, I think, as many of us are very familiar, puts women's lives at risk. It must end regardless, but with so many feeling just the financial catastrophe of this moment, it is more important now than ever that we repeal it.
Well, I would echo a lot of that already. So you had mentioned telemedicine, and I think that's been a huge tool in order to help prevent patients from having to be exposed in the healthcare system to COVID right now. It's been a huge asset in my own ability to provide care for my patients, to be able to follow up with them, reassure them, and having that artificial barrier around medication abortion is really frustrating for many folks. So I think those kind of restrictions that mandate any type of exposure that you have to additionally go to a clinic or to get counseling or to just have arbitrary time limit. All these things just prevent access to care without actually changing any outcomes. People still want the care regardless of how many barriers you put up. It's just whether or not people can actually jump through all those hoops to get there. I'd also echo that I think the Hyde Amendment is a huge barrier to a lot of people. Thinking about my patients, I have several patients that have federal funding for their health care, and if they lose any other type of ability to pay, if they're relying on that health care, they're not going to be able to access that care. So people that are funded through the military, through federal jobs, people that often are essential workers at the same time, that may have exposure to COVID already. We're already at risk. Why put people at additional risk for these arbitrary things that don't actually improve medical care?
Thank you both. I think that is very helpful to understand. And I think it would be also good for, I think, our listeners to understand specifically how your organizations are working on this advocacy effort. And also, I think that COVID in an unusual way has brought people from across different disciplines together to work on the response. And in the field of reproductive rights, I imagine there's also been a lot of collaboration building upon prior collaborations. And I was curious if you could also speak a little bit to some of that interdisciplinary effort. Catherine, I think you're on mute.
So sorry. Yeah, absolutely. So I lost my train of thought. So I think that I spoke earlier to the various lawsuits that are happening. Those were very intense about a month ago, but are in these kinds of stages of stasis. I think, you know, things were changing so rapidly within the first several weeks of the pandemic. I certainly felt like I was focused on ensuring, and still are, focused on ensuring that providers had the support that they need to provide care, especially because delivery of care was changing so quickly. So things were shifting out of the hospital into clinics. And it was really important to not, to be a person that could figure out that information and deliver it to the people who needed it. Because I think the last thing that a provider needs right now is to figure out where to refer a patient to. So certainly helping to figure out referral networks was really important. You know, we were also hearing complaints about partners not being able to get into labor and delivery. And, you know, I certainly just want to flag that as a really tricky issue, given the pandemic and the risks to healthcare providers, and also the really real attention that we are giving to reducing maternal mortality in New York. And then, of course, we were also hearing complaints about continued protest outside of clinics, and engaging with police precincts about, you know, how to encourage social distancing with clinic protesters. An issue that is also certainly on my radar, and Kristen and I have both alluded to it, is insurance coverage. And in particular, you know, insurance coverage for abortion is covered in New York State without a copay. It is also covered by Medicaid. New York is a very fortunate state in that respect. But I'm specifically thinking also about, and that's not to say that there aren't gaps in access, that where providers hear about those gaps, please let me know. But I'm thinking more specifically about insurance coverage for contraception. Last year, we passed a law called the Comprehensive Contraception Coverage Act, and it requires coverage of all FDA contraceptives at no copay. It also requires or allows for 12 months of dispensing, along with coverage of EC at a pharmacy without having to go to a healthcare provider. So coverage of EC without a copay, I should say. So all of those things are actually really important at this moment in time, thinking through how to reduce people's trips out and reduce people's contact in healthcare facilities. So I certainly have been trying to figure out how to monitor compliance with that law, and you know, monitoring insurance plans in New York State is not certainly not the easiest thing in the world, but collaborating with providers, you were talking about interdisciplinary work, and I think one of the, I think my best times working through policy and creating really good policy is when I have been doing it hand in hand with providers, and that is responding to providers' needs, and bringing those back to my contacts, whether it be in the Department of Health, whether it be in the Department of Financial Services, to make sure that our policies are best serving healthcare providers. So certainly, to the extent that people have those concerns, advocates like me are here to help carry that water. And, you know, as I mentioned earlier, all of my work now is kind of seen through a COVID lens to reduce patient and provider exposure to COVID.
Yeah. I mean, I would echo a lot of that interdisciplinary need. and that spirit amongst the people that are on the ground providing the healthcare and the advocates, the lawyers. We need everybody to be part of this. Just again, like on a regular day, there's a lot of work to be done. But particularly now when the healthcare system particularly is swamped, it's overwhelming to be able to provide care and make sure that people can get the care they need, let alone have to figure out all the nuances and the policies and things that can restrict care. So I'm very grateful to all the people that are doing all the policy and legal work to make sure that my patients can get to my door. I think also thinking specifically about what organizationally we're doing. At Physicians for Reproductive Health, we're an organization that helps train doctors to be able to advocate for a lot of these issues. And so at PRH, we're trying to use this opportunity to share the voice of medical experts and be able to share our stories as well as the science with the media. And it's important now more than ever so that we have accurate information out there about what's going on, about COVID, but also about how it's impacting reproductive health care. We're also advocating for things that impact people on the ground. So what can we do to help particularly our vulnerable populations like immigrant families, women that are now out of work, so that we can make sure that we're meeting the needs of our community right now. I think there's just a lot of work to do. And like I said, we need every boot on the ground to be able to get all this stuff done. And so I'm just really thankful to everybody that's been helping. And that includes the people that are staying home and doing their part to be, to help minimize the spread and make sure that our healthcare workers are safe.
Thanks, Chris. And I think, that's a great segue. I was going to ask both of you about how listeners, how individuals, how groups are able to mobilize to support reproductive rights in this time. And perhaps, alluding to what both of you have been talking about, taking an intersectional approach to a response to the COVID pandemic.
Sure. So, I mean, a lot of the decisions about access to care and policies are made on the state level. And so it's important to support, for folks who are listening in other states, it's important to support local coalitions that have organized around reproductive rights, health, and justice in your particular state, as well as healthcare providers. One thing I would particularly lift up that I have been saying to a lot of people, abortion funds and logistical support funds provide funding for abortions for people who can't afford it. They are critical to closing gaps that our government has left wide open. So if you are a person who can give money, or if you are a person who can volunteer your time, it is, again, certainly one of the first places that I send people.
Yeah, I would echo that as well. I would give the standard disclosures to vote, call your representatives, do what you can to make sure that these issues are highlighted to the people that are making these policies. But on a more local level, I think abortion funds are a great start. I'm part of New Jersey's Abortion Access Fund, and this month is actually our fundraiser to try to help raise as much money as possible so that people can access care. And I think a lot of relief efforts, just in general around COVID, are looking not at just donating to this big organization, but what can you do to put money in the pockets of people that need it directly? And abortion access funds do that. They're able to raise money and help fund individual patients and their ability, in whatever gaps they need to access care. So I also would lift that up as well. Also, we had talked about earlier how there's more protesting going on as people happen to be out of work, and which is problematic in itself, but also creating issues around social distancing and safety to patients. So I don't see why we couldn't do the opposite and have more volunteers at these independent clinics that are out there and protecting patients and helping to keep some of those restrictions and those protesters away from the patients that need care. So another thing to do if you are looking for opportunities is to volunteer. Um, but also echoing all the things typically that everyone is talking about: washing your hands, keeping social distance, trying to minimize the impact to the healthcare system as a whole right now, is going to help people be able to access care, because hopefully the spread of COVID will go down. Healthcare will hopefully get a little bit closer to normal, so that people have better access to care.
Thanks. I think that provides a lot of inspiration for many people in terms of getting involved and supporting the efforts that you guys are both involved in. So looking forward, I think, we see so much change during this very strange and unusual time. But at this moment, many of us can also look forward to the post-COVID, at least surge era. And I was wondering if you could talk a little bit about potential long-term negative impacts because of rights restrictions during this time, and also positive ways, positive changes that you've seen that you would hope would persist or continue in the future. So both for policies and care access and care itself, care delivery.
I think that this has fundamentally shifted the way, Kristen, did I cut you off?
No, go for it.
Okay. I think that this has fundamentally shifted the way that delivery of care operates. Somebody was saying to me that the changes that people made in just 2 weeks were changes that could have been made over 6 months to years in our healthcare system, and people were operationalizing those in a matter of 2 weeks. And I think that it all just happened so quickly. And certainly there were people who, had been watching this and understood the implications of what could have happened. But I don't think, certainly I did not anticipate, and a lot of my colleagues in either the advocacy side of things or government did not necessarily anticipate that we would be in this world right now. And that means that we really have to, we are in the midst of this transformation and transition, and it's really hard to say how exactly it will shift policy. But I think, for instance, certainly in the near term, we are thinking about policies in a much different way. So we are elevating policies that might not have had that much attention, like the FDA facility requirement, might not have actually risen to the level of people's attention, but because of the pandemic, it is certainly on people's radar. I think what is also, you mentioned rights, and I just want to go back to that because I think certainly we are also so focused on the pandemic and the challenges that the pandemic is presenting to access to care, that it is also important to realize that we are expecting a major decision from the Supreme Court in June v. Russo, which is the first decision on abortion since Justice Kavanaugh has been sitting on the court, which is something that is a bit bone-chilling. And so we need to be paying close attention to that decision when it comes out. On a larger and perhaps more positive note that you requested, I think it is my hope that this pandemic and the suffering that has it has just clearly caused shines enough of a spotlight on the disparities and discrimination that we really need to face in this country, that we actually have the courage to meaningfully change those systems. So that is certainly my hope. Whether or not America will step up and do that is an open question.
Yeah, I really like that, the inspiration of hope, that this is an opportunity for us to be courageous and to consider what we can do to kind of give a hard reset and think about, we have to rebuild these systems. What can they do? What can we do to make them look different and to make them more equitable? I guess thinking about the negative impacts of the restrictions of rights right now and accessing care, I do worry about what's going to happen once the surge is over. That once things go back to normal, whatever that will be, what will happen to clinics that were shut down? How will they be able to rebuild? What support services will they have for people that have been furloughed or out of work? I mean, a lot of people are joking on labor and delivery about the influx of deliveries that we're going to be having in a couple of months or so. But what part of that is that so many people were unable to access contraception or abortion services? I try not to think about the negatives. I'm really excited actually about the opportunity we have to change things. There's so much that we can learn from this moment. And so all the things that we've highlighted around restrictions and access to care and barriers to care, these are places that we can now work on now that we can see them more clearly. Particular things I think about are how we can really live out those reproductive justice values and all those components that make up someone's reproductive decision making. So what can we do to help our essential workers get a living wage, to have paid leave, how health insurance is linked to jobs, and how if everyone loses their job, it doesn't work. But also things like access to food and water, and I think some of the structural things we've seen around structural racism. This is our opportunity to try to look at those things and rethink our healthcare structures and make them in a way that serves all of the people that we need to serve. So as terrible as this time is, and as hard as it is, both for people at home and people in healthcare, like I'm really excited to see what happens next, and hopefully that we'll show up and we'll be courageous in our next steps.
Thank you. Yeah, I also echo that hopefulness about this post-COVID era and being able to tackle not only reproductive rights, but so many of the other issues that have really been exposed that are related to the health disparities and common, in fact, to the issues that face reproductive rights as well as other human rights. So I think this is actually a good time for us to try to address a few of the questions that have come up. One for you, Chris, is can you talk a little bit more in detail about how you've made use of telemedicine in both family planning and abortion care during this time? And perhaps you can also speak to other changes that you're aware of around shifting gestational age for medication abortion, or utilizing telemedicine specifically potentially for follow-up or other aspects of care. Another one that many listeners may have heard of is the National Abortion Federation's kind of no-touch system. So if you could just speak a little bit to the details of those.
Sure. Like I said earlier, I think this is a great opportunity to think about the science that we have and apply it in the best way possible to help our patients access the care that they need without, causing additional harm. So there's been a lot of interesting conversations around telemedicine and how we can use that in family planning services. So just to illustrate what the no-touch abortion is, many places traditionally have done a lot of testing around patients seeking medication abortion, things like blood testing, ultrasounds, which medically, based on research, haven't been shown to improve outcomes. But it's always something that, we've always done. It's always been the traditional way of doing things. And this pandemic has helped broken down some of those things. So the no-touch abortion essentially would be counseling a patient via telemedicine about their abortion options, talking to them to distinguish how far along they are, any medical risks, And then a patient would verbally consent, sign consents via telemedicine, and then come to a clinic to pick up a bag with their medications, and then potentially have a urine pregnancy test to check in a couple of weeks versus just having a follow-up call with the provider. It's a really great idea. And I'm hopeful that, we won't lose sight of how great of an idea it is and how great of an option it is for many patients. For me personally, I've been working toward that. And again, unfortunately, people in medicine are very stubborn about moving things in a different direction from tradition. But I've been doing follow-up for my medication abortion patients via telemedicine, doing contraceptive counseling over telemedicine, and just sending prescriptions off if they're needed. There's been a lot of interesting talks about using Depo-Provera, which is the contraceptive injection, sub-Q, and having patients inject it themselves, which has just been approved in California for insurance coverage to do that. So there's a lot of opportunity.
And which is, I'll just add, Kristen, and which is should be covered by plans in New York State under the CCCA.
Awesome, thank you for that. So yeah, there's a lot of different opportunities that we can now rethink things. You alluded to medication abortion extending their gestational age, and the National Abortion Federation had recently recommended that you could extend to about 12 weeks with medication abortion, giving an additional dose of the second medication side attack. So I think people weren't necessarily on board to do it just because it takes a long time to change things, but now we're rethinking, well, what can we do to keep our patients safe? And we have good evidence for it, so why not push these new innovative medical techniques and recommendations forward?
Great, thank you. Yeah, that's really helpful. And as Catherine kind of alluded to before, things that used to take a very long time are now happening very, very quickly. And I think even the variation that we're seeing across states and changes can be motivation or inspiration for others across the country to start pushing for these changes quickly. We have another question, and I know that we've addressed this a little bit, but the focus has often been on access to abortion during this pandemic in terms of what people are reading and what people are seeing, and less so about other family planning methods, different types of birth control, long-acting methods. So I was wondering if you guys could speak a little bit more specifically to efforts around family planning methods, as well as over-the-counter prescriptions and things like that.
Sure. So I noticed in one of the comments that they were also talking about, could this help push birth control to be over the counter? I think we certainly have been talking about, in terms of FDA restrictions, the REMS requirement that abortion be dispensed in a clinic, and how that has been a problem. But I do think that is differently situated than, or perhaps closer to the finish line, or should be closer to the finish line than perhaps birth control over the counter in this country. So it has not been so much of a conversation in terms of shifting the FDA right now in this administration. It's too much of a long shot. Certainly that should be something that is top of mind when this administration hopefully shifts this November or in the future. But I do want to lift up again, insurance coverage for contraception is really key. It is under state law, New York state law, very well covered. And I'm talking about every single type of contraceptives within 18 FDA categories is covered. So that is beyond what the ACA covers, which is one type in every category. This is every type. And so that includes Depo sub-Q. So, and also the 12-month dispensing piece is obviously really important, as well as EC, getting EC at the pharmacy without a healthcare visit, using your insurance coverage. So those are things, I mean, I think one of the tricky things that providers run into with insurance coverage for contraception is that it is often difficult. And I think that we're trying to figure out how to resolve this, but it is often difficult to figure out or anticipate when a plan is self-funded. And self-funded plans do not have to comply with state law. They fall under federal law because of a law called ERISA. So because of that, it is important to make complaints. It is important to, lift these things up for advocates. It can sometimes be frustrating when you've made a complaint and that plan isn't even covered by state law, but we are trying to put together a one-pager for providers to better anticipate when a plan is self-funded. And the law, or I should say that the state is also going to, they have not yet, but they are going to require insurance cards to tell a provider when a plan is not self-funded. So that will certainly be an indicator as well.
I'll add that around contraception, even though a lot of the logistics around healthcare are changing, my counseling has been the same. That I still want to make sure that patients are aware of all of their options around contraception, including things like IUDs and implants, where logistically that may be a little bit more challenging than calling in a prescription. But if that's the best method for that particular person, then we have to figure out a way to make sure that they can access that. So I want to highlight that we're still trying to minimize coercion around people's contraceptive decisions. So for example, if someone wants an IUD, I'll still have a conversation with them perhaps over the phone instead, so they just can come in, get their IUD and leave with minimal exposure to the healthcare system if possible. I also wanted to mention around that idea about accessing changing methods, discontinuation of methods, that should always still be available to patients. There's a lot of concerns around people that have long-acting forms of birth control that then lose access to healthcare, either because of insurance issues now, or just generally don't want to come back to the clinic. What they can do to help remove an IUD if they need to at home, or have access to removal of an implant for bleeding issues, because we don't want to force people's hands and to use contraceptives that they don't want to use because of a limited access to healthcare. So the hope is that these things like telemedicine should be helping us to reach more people and be able to give them the care that they need, and still figuring out the logistics around providing all options to people.
Yeah, thanks for that. I think those are also important issues to bring up around, the restriction of healthcare access actually leading to potentially coercion within contraceptive choice. Mm-hmm. I guess we've kind of talked a little bit about this, but perhaps you both have more thoughts on examples of where in certain states, instead of restrictions increasing, there's more of an expansion of services in this moment, along the lines of the telemedicine that we have been talking about earlier. But I don't know if there are specific examples of significant expansion of abortion care access and how that may be affecting the overall advocacy effort.
I feel like Kristen could probably speak more to the actual quantifying of patients. I mean, I think what I was hearing from providers, at least during the first few weeks of the pandemic, and then of course leading up to the peak here in New York, was that there were actually less patients coming in for care, that patients were self-delaying. But Kristen, please, you I'm sure know more than I.
I mean, I would say that was in my practice, that was similar, that less and less people actually were coming to care. which to me was kind of sad because I actually finally had protections for abortion services in my state, but no patients to be able to provide those services to. So telemedicine was a good opportunity to be able to reach people that were initially concerned about coming in, to help bridge barriers and help minimize exposures if possible. I think also in the wave of things changing to accommodate COVID, there were also a lot of people expanding different ways to access care. So some things that I heard about in different states were that advanced practice clinicians, like nurse practitioners and PAs, could start providing all types of care that may not have been initially part of their practice, and abortion and contraception care could have been part of that. So expanding the amount of providers that are able to provide abortion is huge. They also, at one point, had lifted restrictions about state barriers on medical licenses. And so I wonder how that also could have been applied for people that travel to other places or are interested in traveling to other places or providing telemedicine for other states. So I'm hopeful that those changes may be something that we can look at long term and see those effects, see that things are safe, and be able to continue those things to minimize barriers.
I mean, I think that we're certainly looking at old regulations that may not be in effect, but are acting as a barrier to care in New York. We are looking at those and considering potentially raising those with the Department of Health to say, you know, it is time to get these off the books once and for all, if that was not totally clear in this crisis. So that it has opened up certain opportunities, I think, to increase access to care. So I mean, it's a well-pointed question.
Another question we have here is related to the economic recession that we see coming ahead. And this question is asking, what risks do you see in this potential prolonged recession in holding politicians accountable to pro-choice action?
I'll pass that one on to Catherine.
Well, I mean, it's a really big question, and one we could probably spend the next hour on. I mean, I think in uncertain times, people are typically tend to want to throw the leaders out of office. You know, we will see what the effect of this pandemic is on the election. We do not have a roadmap here, or at least I'm not familiar with a roadmap here. You know, I do think when it comes to the various gag rules that the question referred to, I mean, those gag rules flip on and off depending on the administration. Or I should say the gag rule flips on and off depending on the administration. And we now have a political candidate on a pro-choice political candidate that is on board, has not always been, but is now on board with repealing the Hyde Amendment. So I think it is a matter of certainly lifting up, for instance, the Hyde Amendment in the particular current struggle that people are facing, given the economic strife that this has created.
Thank you. So I think, you know, we are down to our last couple of minutes, but I don't know if either of you have kind of a closing point that you want people to take home with. I think you've both provided a lot of inspiration to not only get in touch with Congress people and elected officials, but also to reach out to local efforts and emergency funds to really support reproductive rights during this difficult time. But yeah, I'd like to give each of you a minute to just give a closing statement if you'd like.
You know, I certainly, like Kristen, I think about this kind of care. I think about reproductive rights, health, and justice a lot. not so much on the healthcare delivery side of things, but on the policy side of things and on the legal side of things. And I just want to say that even though perhaps a lot of the audience that attended today also is in that boat, most of the people around us aren't. So it's important, I think, to lift this up, you know, certainly for our representatives, but to make sure that people are connecting this to other types of discrimination, so that people understand that reproductive rights, health, and justice is a matter of, you know, racial equity. It is a matter of economic equity. It is a matter of environmental equity, so that we can continue to weave it in, into the things that we are lifting up and hopefully changing over time.
Well, thanks again for this opportunity. And I think along with that, one of the things that's been the most humbling is just the sense of community that everyone has right now. And I see that within healthcare, that doctors and nurses and janitors and everyone that's been working in the system that may not know each other, they may have never like really introduced each other, are now part of a big family, and more so than normal. And I think in communities that we're helping out our neighbors a lot more. We care more about our local businesses now than we had before. And so I'm hopeful that we don't lose that sense of community when this surge is over, and thinking about that within our reproductive health rights and justice movements, that we need that community to humanize this care, to make it more than just the politics that we see every day, and to recognize that people are going to get this care because they need it, because of their whole life situation, that this is essential care. And so if we just talk to each other and humanize each other's experiences, I'm hopeful that we'll get more people on board and hopefully help improve access to care in the future.
Thank you so much. Thank you so much to Catherine and Chris and Randy for joining us today and sharing your work and educating us on so many different issues related to reproductive rights. And thank you for all the listeners who were able to join. We will have a recording of this webinar available up tomorrow. And I also want to inform you of our webinar for next week, which will be on Wednesday, May 6th from 3 to 4. And we will have Doctors Massey and Curcio discussing Elmhurst Hospital, saving lives and looking forward to the epicenter of the epicenter. So thanks again for joining, and take care.
Thank you.
Thanks so much.